in local and international forums, and he's a very familiar speaker to our local audience. So today he'll be taking us through the therapeutic advances of management of chronic liver cell disease. Without further delay, let me invite Professor Anuradha to take on the mic and continue the proceedings.
Thank you, Rohan, for that kind words of introduction. Can you all hear me, Rohan? Yeah?
Yeah, can hear clearly, yes.
Okay. So first I would like to thank the President and the Council of Sri Lanka Society of Gastroenterology for inviting me to give this talk on therapeutic advances on the treatment of chronic liver cell disease. So objectives to my talk today to discuss mainly drugs and other measures used in the treatment of first compensated cirrhosis, then decompensated cirrhosis, and some complications of cirrhosis like ascites and variceal bleeding, and also some symptoms of cirrhosis like cramps and pruritus and frayed. So cirrhosis is predicted to become one of the most common causes of death in the productive age group in the future, in par with ischemic heart disease, stroke, and malignancies. But unfortunately, it has not got the same publicity as the other more well-known diseases like heart disease. But cirrhosis is going to become equally important as one of the main causes of death in the future. Transplantation, which is the definitive treatment, is very difficult. I will tell you exactly why. And there are major advances in the management of chronic liver disease, which could delay decompensation and death. So what is compensated cirrhosis? That's cirrhosis without past or present ascites, encephalopathy, or upper GI bleeding. And these patients are asymptomatic and usually diagnosed accidental. So decompensated cirrhosis is cirrhosis with past or present ascites, encephalopathy, or upper GI bleeding. And these patients are usually symptomatic. They can have fatigue and other symptoms of cirrhosis. And when they present with any of these features of decompensation, life expectancy without a transplant is very limited. And unfortunately, most of the patients with cirrhosis present with an episode of decompensation. This is true even for developed countries. So what is advanced chronic liver disease? It's a broad term which may include some patients with advanced fibrosis who carries same risk like development of hepatocellular carcinoma, but without full-blown cirrhosis. By the way, cirrhosis is a histological diagnosis. So when we diagnose advanced fibrosis on fibroscan, some people are reluctant to call it cirrhosis. So they are given this name, advanced chronic liver disease. Now we can diagnose advanced chronic liver disease with a fibroscan, which is the new kid on the block. And if the liver stiffness measurement is less than kilopascals, we can safely rule out advanced liver disease. And if it is more than 10, which is suggestive of chronic advanced compensated liver disease, and if it's more than 15, it's highly suggestive of advanced chronic liver disease. This is a fibroscan, something similar to the ultrasonography with a probe and a screen, and it gives a report like this with two values, one the CAP score, which gives you an estimate of the fat content, and another measure in yellow number, which gives you the stiffness of the liver. Here in the left hand side, liver stiffness is 3.5, which is very normal. And on right hand side report, there is a stiffness measurement of 33, which is corresponding to advanced cirrhosis, like this, like what you see in this picture. 33.3 for the cirrhosis patient, and a normal person with a normal liver have something less than 8. So this is how the fibrous value, liver stiffness given by the fibroscan corresponds with the histology. When it is above 12, then it corresponds to cirrhosis on liver biopsy. So various stages are there in between. So this is what happens when you have cirrhosis. Say, imagine if you have a normal liver up to the age of 20, if you start, due to various reasons, start having fatty liver at the age of 20, if you have if you have the risk factors which could lead to advanced liver disease, you could be progressing at various rates. So here in this picture, imagine if you have fatty liver at the age of 20, by 30 you could have some fibrosis, by 40 you could have cirrhosis, and by 50 you could well have decompensated cirrhosis. So it's a fairly prolonged illness. One good thing about this is that in between you have enough window of opportunity to intervene before one set of cirrhosis. So we have maybe 30-year period where you can have various interventions to allow the prevent the patient from going into decompensation at the age of 50 years. So why should we take care of the patient with compensated cirrhosis? Because we have a 30-year period to active, roughly 30-year period. So because transplantation is not an option for most patients with cirrhosis. Why? Because it's very costly. There is major organ shortage, expertise, because not all people can do transplants. And the candidate is not suitable because of the comorbidities like kidney illness, heart illness, and advanced age. And even in developed countries, less than 25% of the patients with decompensated liver disease receive a liver transplantation. So what do we have? We have a window of opportunity to delay decompensation and death by interventions before they reach that advanced stage of cirrhosis. And for this, we need cirrhosis to be diagnosed as early as possible. So how do you diagnose cirrhosis early? By screening programs. Now, there are very clear guidelines for patients with high-risk factors, like high-risk groups like diabetes. And there are very clear guidelines on how to detect advanced fibrosis in patients with non-alcoholic fatty liver disease. So then again, as medical practitioners, we should have high index of suspicion in patients who are at risk of developing liver disease, like patients who are known to have alcohol use disorder, patients with family history of cirrhosis and hepatocellular carcinoma, patients with who are on drug abusers, patients on blood transfusions who have a risk for acquiring hepatitis C, and so on. And sometimes cirrhosis is accidentally diagnosed by surgeons at surgery or laparoscopy under direct vision. Then they refer the patient to us. The hematologist, when the investigations patients with thrombocytopenia, they detect cirrhosis and send the patients to us. Radiologists, when they do ultrasonography for various other illnesses, they diagnose chronic liver cell disease and refer them to us. And also sometimes at medical checkup programs in the private sector, they also detect patients with cirrhosis. So when you diagnose a patient with compensated cirrhosis, what's the next step? Here we have someone who is very asymptomatic, and he probably will understand the gravity of the illness, so he will not be forthcoming readily to seek medical advice. So what should we do? So this is what we should be doing. First, stage the cirrhosis. So a compensated cirrhosis patient has two stages where they have clinically significant portal hypertension, or there is no such clinically significant portal hypertension. Because what do we know? What should we know whether this patient has clinically significant portal hypertension? That's because if we start them on non-selective beta blockers, it's very clearly shown that we can delay decompensation, not only for variceal bleed, also other forms of decompensation like ascites. So new advance is that we can detect. Earlier we used to do endoscopy to check for varices, but now because we have the fibroscan, now there are various non-invasive methods of diagnosing clinically significant portal hypertension. So if you have fibroscan, if the liver stiffness measurements is more than 25, you can diagnose or suspect clinically significant portal hypertension. If the liver stiffness is between 20 and 25 kilopascals with a platelet count of less than 150,000, again you can suspect clinically significant portal hypertension and start them on non-selective beta blockers. And if the liver stiffness is further low, it's around 15 to 20 kilopascals, and the platelet count is less than 110,000, again you can suspect clinically significant portal hypertension and start them on RD. So this is what we used to do endoscopy, and there is varices or no varices. If there is varices, it was called stage 2. Now we call it clinically significant portal hypertension. So what's the life expectancy in these patients? When they have no clinically significant portal hypertension, they are expected to live for more than 10 to 20 years, especially if we remove the etiology. But when they decompensate and develop ascites, the life expectancy drastically reduces to around 3 years, 3 to 5 years. When someone is on regular paracentesis, it drops further to around 6 months. So, but compensated cirrhosis, the patients can have unexpected deaths. I told you that they are expected to live for 10, 15 to 20 years, but how could they die? They could die of liver cancer, acute on chronic liver failure due to various forms of hepatitis. In Sri Lanka, hepatitis A, dengue, then drug-induced liver disease, herbs, then alcohol binge. So these stable patients, so our duty is to avoid them, prevent them from acquiring these well-known risk factors for the onset of acute on chronic liver failure. So we can do vaccinations, we can ask them not to take high-risk medications like non-steroid and anti-inflammatory drugs or anti-TB drugs if possible. We can stop them from taking alcohol. And our objective is to prevent these people. So if we prevent these and we do the liver cancer surveillance every 6 months, then these patients are expected to live longer. And also they can die of other illnesses like myocardial infarction, because in NASH cirrhosis, the highest risk is from cardiovascular death. So at the same time, if you are managing these patients, you should look into the other risk factors as well. So can we delay progression in these patients with compensated cirrhosis? Yes, we can. So this should be our objective. So this is from Andy Burroughs, the famous British hepatologist who passed away about 7-8 years ago. Just before his death, he wrote in the Lancet, I quote, "The new concept in management of patients with cirrhosis should be The prevention and early intervention to stabilize disease progression and to avoid or delay clinical decompensation and the need for liver transplantation. So he's a transplant hepatologist. The challenge in the 21st century is to prevent the need for liver transplantation in as many patients with cirrhosis as possible, I unquote. So we'll see whether we could act accordingly and delay decompensation. So how can we delay progression of compensated cirrhosis? There are specific measures and general measures. So what are the specific measures? Treat the underlying cause or remove or suppress the primary etiological factor is the number one method of delaying decompensation. I will come into that in detail. Then surveillance of liver cancer, vaccinations again, all possible preventable illnesses, infections, especially hepatitis A and B. And to tell you, more than 50% of our patients with cirrhosis are non-immune for hepatitis A. They are very unlikely to survive hepatitis A if they get. So vaccination against hepatitis A and B is mandatory. Then varicose surveillance and detection of clinically significant portal hypertension. If you have methods of identifying it without an endoscopy, then start them on carvedilol therapy or non-selective beta blocker therapy. And some other medications like statin, I will come into that in detail. Right. So removal of the suppression of the primary etiological factor. We all know that all these diseases can be treated. Hepatitis B, antivirals, hepatitis C, antivirals, autoimmune hepatitis, steroids, Wilson's disease, penicillin, hemochromatosis, venesection, and alcoholic liver disease, abstinence. So this is absolutely important because if they do that, they are unlikely to progress fast into decompensation. Fatty liver, treat diabetes, treat obesity, treat hyperlipidemia, and maybe vitamin E and obeticholic acid in very early disease. We have some evidence for vitamin E, but obeticholic acid, there's this reverse trial which is on testing obeticholic acid in very early cirrhosis because it's effective in reversing fibrosis in non-alcoholic fatty liver disease, and the results are awaited. So immunizations, I told you about this, hepatitis A and B, COVID, then avoiding high-risk medicines. That is something we don't take very seriously. This is absolutely important because, say, for example, diclofenac sodium pill can kill any of these patients. They can kill anyone, even a patient with a normal liver. But if you get because they have very poor liver reserve, these patients with compensated cirrhosis, although they are asymptomatic, they may be having only 50% of the liver reserve. So if they develop a drug-induced liver injury, they are unlikely to survive. So NSAIDs like diclofenac, methotrexate, coamoxiclav, all are non-liver toxins, herbal medicines, anti-TB medicines. So if we can avoid these medicines correctly, because our patients are very fond of medicine. So even if they have a very less serious kind of joint pain, they go and meet the family doctor who is very unlikely to know this fact that they should not be receiving NSAID. So they are very likely to receive NSAIDs, which could kill a patient with well-compensated cirrhosis. Then general measures, weight loss, good nutrition, I'll come to that in detail, exercise, then avoiding alcohol and smoking and coffee. And coffee intake is known to improve survival. Sarcopenia, I had to talk on sarcopenia in detail, something new. And we should know why these people develop sarcopenia and what can be done to prevent it, because it's associated very significant poor prognosis even after transplantation. So should not allow them to have sarcopenia if possible. So these are the reasons for sarcopenia: nausea, poor nutrition, various other mechanisms like micronutrient deficiency. And possible interventions include good quality nutrition and and physical activity. So proteins, calories, late night snack to prevent long hours of fasting. This is something new because these patients with cirrhosis, so a normal person can live up to even 48 hours without catabolism of the muscle. But these people with even compensated cirrhosis, they can develop muscle catabolism for proteins even after 12 hours. So what you should do is to make sure that 8 p.m. dinner and 8 a.m. breakfast may not be good for them. So they should try to have something late in the night before bed, like 10 p.m. and something very early in the morning. So prevent long areas of long hours of fasting, because the moment they fast, it adversely affect the muscle. So, and also they should need muscle strengthening exercises to keep good muscle mass. So any pharmacological treatment with survival benefit, so non-etiological factors or chemoprevention as it's called now. So what are the drugs with good evidence that will delay decompensation? Statins and carvedilol or beta blockers. So best evidence is for statins and carvedilol, and there's some evidence for metformin, ACE inhibitors, angiotensin receptor blockers, and aspirin. This is from the latest 2021 Bavino guidelines on portal hypertension. So there's major substance into this. So even aspirin. So I will take one by one. But these are still not recommended by the guidelines. We do have studies, not very strong evidence. A lot of trials are on these drugs, but we could easily use these drugs in most of the patients that we see. Most of them will have diabetes, and now according to diabetes guidelines, after 40 years, all of them should be on a statin. So what the Bavino guideline says that if there is an indication for statins, please continue it. Don't stop. So same with uh, uh, metformin, ACE inhibitors, and aspirin, but there is no strong evidence for metformin, aspirin, and losartan, but there is stronger evidence for statins, and there is very good evidence for carvedilol. So statins theoretically beneficial, observational studies, a lot of good evidence, animal studies, good evidence, at least one randomized controlled trial with more than 150 patients shown survival benefit, and at least 4 big randomized controlled trials are on, and results are awaited eagerly. So these are the statins. It reduces angiogenesis, may prevent or retard the onset of hepatocellular cancer, reduces inflammation, reduces fibrosis, reduces endothelial dysfunction, and so on. So what's called pleiotropic effects of statins. And this Journal of Hepatology article a few years ago started talking about statins big time. So all drugs as new therapy for liver disease, and statin is the front runner for delaying decompensation in patients with compensated cirrhosis. So if they have an indication, you can start statin. Like I said, diabetic above 40, you can always start statin. And most of our patients with cirrhosis following NASH cirrhosis are diabetic. So we can easily start maybe 75% of patients with cirrhosis on a statin straight away. So statins improve survival, and continue statin if there is an indication. That's what the Bavino 7 consensus published this year. So then beta blockers, non-selective beta blockers, especially carvedilol. So carvedilol is beneficial in preventing decompensation in patients with clinically significant portal hypertension. Not just bleeding, it prevents decompensation, which include ascites and other complications. It's more effective in reducing hepatic wedge pressure gradient than propranolol, greater benefit in preventing decompensation, better tolerated than propranolol, and has a survival benefit. This is the trial, randomized control trial came 2 years ago in Lancet. So carvedilol, all patients with evidence of clinically significant portal hypertension should be on a beta blocker. And now we can start beta blocker without endoscopy, as I described earlier. So metformin has been shown to be beneficial, reducing the incidence of NASH-related HCC, but not randomized. All these observational studies. So if you have a patient, compensated patients with diabetes, please do continue metformin. Same with ACE inhibitors and angiotensin receptor blockers. Continue them. They have hypertension or any other indication. And you have to stop these drugs if the patient develops ascites, because if the patient has ascites, these drugs are contraindicated. Same with aspirin. Do not omit aspirin in patients with compensated cirrhosis if indicated, like ischemic heart disease or stroke. Reduce the progression of fibrosis in NASH. That is observational study, and reduces the incidence of hepatocellular carcinoma. Again, observational study. And by so Bavino consensus statement says to continue aspirin if they are indicated for any other illness. So what is not indicated in compensated cirrhosis? These drugs like lactulose, rifaximin, diuretics, proton pump inhibitors are not indicated in patients with compensated cirrhosis. So that's all about compensated cirrhosis. Now I will touch on decompensated cirrhosis with these objectives: managing complications like ascites and varices, management of symptoms like pruritus and cramps, and discuss few drugs with survival benefit in decompensated cirrhosis. So decompensation is, it's not just loss of liver cells and portal hypertension. Decompensation involves so many mechanisms. Now only people are realizing that it involves so much of other pathophysiological mechanisms like inflammation, gut microbiome, circulatory dysfunction, mitochondrial dysfunction, oxidative stress, hyperammonemia, energy consumption defects, and so on. So people are working on these lines, doing various trials to see whether we can identify any molecule that will be beneficial in these patients with decompensated cirrhosis. At the moment, we don't have a lot to offer for patients with decompensation other than a liver transplant. So drugs probably useful with a survival benefit. Antibiotics, because they prevent spontaneous bacterial peritonitis. Rifampicin is rifaximin, I'm sorry. Rifaximin, statins, albumin, and again NSSB beta blockers, non-selective beta blockers like carvedilol. There are a lot of drugs in development on lines that I mentioned earlier, and sometimes tips also. So this is the liver hope, the large trial, ongoing trial with simvastatin and rifaximin combination in decompensated cirrhosis. So the study had two arms. One to see the safety, because people are too scared to use simvastatin in cirrhosis. This is decompensated cirrhosis. 10 years ago, if you discuss this as a medical student, you should fail the final exam. Should have failed the final exam because it was contraindicated. Now we are talking about simvastatin, a statin in decompensated cirrhosis. Now this study results are out. It is safe. The 20 milligrams of simvastatin can be used safely in patients with decompensated cirrhosis. Right. The next arm is you combine simvastatin 20 with rifaximin 1.1 grams a day to see whether they have survival benefit. The trial is on. Probably we'll see the results soon. So if you are using simvastatin, the dose is simvastatin 20 milligrams. Then human albumin is just not a volume expander. Like statin, it has so many other effects: antioxidant, binds various toxins, molecules. It has endothelial stabilization. It has anti-inflammatory effects and immunomodulatory effects. Because of that, human albumin has shown to be beneficial in answer study uh, for patients with grade 2 and this moderate volume and large volume ascites stable patients. This is the dose 40 grams of human albumin BD for 2 weeks, 40 grams weekly for 18 weeks. That's nearly 6 months. So reduce incidence of complications and improve survival. So the issue is that whether we can use it, because so costly to use albumin. So I think these type of treatments should be reserved for people who are transplant candidates, basically. Right? We should have a good reason for using these type of interventions in cirrhosis, but still not, because so many studies showing that it's not beneficial. Because of that, it's still not recommended in any of the guidelines. So what are the current indications for human albumin? Hepatorenal syndrome, AKI, spontaneous bacterial peritonitis treatment on day 1 and day 3, and large volume paracentesis to paracentesis if you have more than uh, 5 liters to prevent circulatory dysfunctions. And if you use albumin beyond these indications, it could well be detrimental also. So albumin has its own problem. So it's not a drugs that should be used without a proper indication. So treatment of complications, little bit on treatment of complications, variceal bleeding, hepatic encephalopathy, hepatorenal syndrome, ascites, hyponatremia, and portal thrombosis. I will discuss briefly only on new developments. Variceal hemorrhage, carvedilol is preferred over propranolol. Banding ligation if carvedilol intolerant or fail in the primary prophylaxis. This is Bavino 7. Tips in uncontrollable bleeding with banding ligation or medical therapy. Tips has shown to be beneficial and has a survival benefit who fail to control bleeding with banding ligation and terlipressin that we use as the medical therapy. Hepatic encephalopathy, what is new? Muscle is critical for catabolism ammonia. So avoid sarcopenia. So what can be done to avoid sarcopenia? Adequate protein and calorie intake, that's nutrition, and avoid late avoid fasting as I described earlier, to have a late night snack. So reduce the periods of fasting. You can ask them to have a glass of milk or piece of cheese or whatever, some snack before bedtime. So, and third, the second thing that I want to tell is that there's a recent trial, very recent trial, saying that in patients with severe encephalopathy, intravenous LOLA, L-ornithine, L-aspartate reduces mortality when combined with lactulose and rifaximin. It's a randomized controlled trial published in Hepatology last year. So there is good indication to use intravenous L-ornithine L-aspartate in combination of lactulose and rifaximin. Ascites, what is new? Maybe you can use SGLT2 inhibitors like empagliflozin in patients with diabetes and ascites. So that's something new, because it is known to help diuresis with other diabetics. Tips to be considered if large volume paracentesis is needed frequently. There are clear guidelines on how to use tips. The only issue is whether tips is feasible in our country. Tips is absolutely costly. I think in the private sector cost about more than ₹1 million. Need expertise, need to buy this tips apparatus, then the stent, and then I don't think it's available in the government sector at all. these stents. So TIPS is something effective, and unfortunately we can't use TIPS in most of the patients due to logistics. But TIPS should be used as a bridge to transplantation like in most countries. So TIPS something that we don't do frequently, but there's clear evidence for TIPS in patients with variceal bleeding uncontrollable by conventional methods and resistant ascites, and sometimes hepatic hydrothorax, and sometimes portal vein thrombosis also. So hyponatremia, anything new? We all know about fluid restriction, stopping diuretics, and albumin infusion may be helpful in some people. And whether we can use hypertonic saline? Yes, in very severe symptomatic hyponatremia like coma and seizures, and again as a bridge to transplant. Vaptans, tolvaptan is recommended finally in the American Association Study of the Given AASLD, the American Association Guidelines, as a very short-term treatment as a bridge to transplantation. Okay, HRS, I'm sure you know the new nomenclature is earlier called type 1 HRS, acute renal injury due to acute renal failure due to liver failure. HRS, now it's called HRS-AKI. And what's new about HRS-AKI is that early present infusion. Now, earlier we used to give bolus like 1 milligram 6 hourly, 2 milligrams 6 hourly. Now we know that early present infusion could be more effective and less costly and has less adverse effects. So can use 2 milligram of 24 hours and titrate up till you achieve some kind of improvement of the renal function. Noradrenaline also effective if 12% is very costly, but noradrenaline is effective in as effective as 12% in some studies, but need ICU admission. And CKD is also common. If there is rise of creatinine, should check whether it's not easy to differentiate CKD because most of these diabetics, NASH, they will have some kind of renal impairment due to CKD. And if there is CKD, then these drugs will probably not work. So we have to identify whether they have CKD. So how to identify CKD? Difficult, but say normal leukocyte sediments and normal no protein urea in urine, that will help to differentiate. So no specific treatment for CKD. Nephroprotective agents like ACE inhibitors are contraindicated at this stage, and finally if they have CKD, then they may need a combined liver and kidney transplant. So portal vein thrombosis, screening for portal vein thrombosis recommended in all patients who are candidate for liver transplantation. Recent portal vein thrombosis, symptomatic portal vein thrombosis in patients awaiting liver transplantation, more than 50% occlusion or less than 50% with superior mesenteric vein extension are candidates for anticoagulation, and you can use low molecular weight heparin, warfarin, or direct acting oral anticoagulants in childs A and B, not in C. Okay, symptoms, we want frailty. Can you do something for frailty? Nothing much other than nutrition. Pruritus, we all know that we use cholestyramine basically on data from cholestatic liver disease, nothing new. Muscle cramps, again, nothing new. Baclofen works, but unfortunately, there's no evidence of vitamin E, according to one of the latest articles. Sexual dysfunction, teladophil may have benefit, according to this trial in Journal of Hepatology International last year. Futility, so I want to discuss this a little bit more. So decompensated advanced chronic liver disease, so decompensated cirrhosis patients, when transplantation is It's not an option due to age, comorbidities, social issues. Do we have enough palliative care in place for these people? So is it worth to sustain life on terlipressin, albumin, meropenem for days and days? One day's treatment costs 100,000 rupees. It's common. They have to be imported in dollars, 100,000 a day. So is it really worthwhile? That's something that we do not do in our country. I think we should have a broad discussion on end of life decisions in cirrhosis. They should allow to die in dignity, die with dignity, like in all other illnesses. So most of the other illnesses, there is some plan on palliative care and end of life decisions, but not. I haven't seen that's happening in cirrhosis. So something for us to discuss. This neglected topic in palliative care for patients with end-stage liver disease who are not candidates for liver transplantation. So when to transplant, upper GI bleeding, episode of encephalopathy, diuretic-resistant ascites, liver cancer, and results are best when transplanted early for very carefully selected, deserving patients. Fortunately, we have a program and becoming successful. So first liver-related donor transplant in Sri Lanka, first pediatric transplant, and first transplant for the acute liver failure in the country. So we have experience and we are ready to help these patients who are deserving and very carefully selected patients who should be investigated and worked up pretty early in the illness. So to summarize, Chairman Sir, ladies and gentlemen, compensated cirrhosis should be diagnosed as early as possible to delay decompensation by interventions. Removal of the etiology is the most important intervention. If you see an alcoholic, some or other, just let them stop alcohol. That will improve their liver functions tremendously. Clinically significant portal hypertension should be diagnosed and treated with non-selective beta blockers. Statins and beta blockers could delay decompensation. We are expecting robust evidence, but if you have these patients, please start them. Statins, beta blockers, rifaximin, and albumin may have survival benefit in decompensated cirrhosis. Patients with decompensated cirrhosis should be evaluated carefully for liver transplantation. Selected deserving patients should be offered liver transplantation early in the illness. Thank you very much, ladies and gentlemen. Wish you a very pleasant evening. If there are questions, I can take a few questions, Felicia.
Yeah. Thank you, sir. Thank you for that very interesting and up-to-date lecture. There are a few questions, mainly about albumin. With low T half of albumin, how effective is it? Giving albumin with low T half.
Well, these are clinical trials. I know that it has very low T half, about 3 days. So I really do not know how it works, but as I told you, it has so many other properties other than volume expansion. They're like statins. So many other. Now people are talking about anti-inflammatory properties. So many properties of albumin. So maybe that it's when it's given in the long term. Still, these results are controversial because there are 2-3 studies. Only one study has shown it to be beneficial in the long-term treatment, that is months and months of albumin treatment in stable patients with grade 2 and grade 3 ascites only. So, but there are very clear indications like spontaneous bacterial peritonitis, hepatorenal syndrome, and prevention of circulatory dysfunction in patients who have large volume paracentesis. Those three indications we knew, but this is the new indication, and this is by a European group by Paolo Angeli, and they are very, they is from Italy, and they have enough money to give albumin for this paper. So I really do not know how it works exactly, but this study evidence. So we have to believe study evidence unless you prove with another, is disprove with with another study.
And what are the adverse effects of albumin?
Yeah, if you give too much albumin, there can be respiratory issues. So that has also been shown, and they say very clearly, don't give it more than what is necessary. So if you give it maybe more than 14 days or whatever, there have been issues with adverse effects due to albumin. That's very well recognized.
And so what is recommended is to give salt-free albumin, am I right? But we don't have that here. Yeah.
Salt-free albumin is available, but it's very costly, Felicia. It's the normal salt albumin is also very costly, but salt-free albumin is available, or low salt albumin is available, which has lower salt content than the conventional albumin. That's more expensive than the conventional albumin.
Is hypertonic saline indicated in hyponatremia in CLCT? I think you already discussed it.
Yeah. In severely symptomatic patients with in coma, patients with seizures, or very low sodium, like less than 110. Yeah.
What is the place of vitamin D testing and treatment?
Vitamin D.
Vitamin D, yeah.
D. Yeah.
D.
So, studies say that 20% of patients with compensated cirrhosis and about 60% of patients with decompensated cirrhosis are vitamin D deficient. So vitamin D should be checked and treated, but the cost of vitamin D level in Sri Lanka, 10,000 rupees. So maybe short term, even without testing, maybe in all decompensated cirrhosis patients, and maybe selected patients with compensated cirrhosis, short term. Yeah. So there is place for vitamin D replacement. Yeah.
Place of bilirubin, AST, and INR in liver disease. It's a very broad.
Broad question. Place for what?
Bilirubin, AST, and INR.
Yeah, bilirubin is raised in decompensated cirrhosis. I talked to you about ascites, encephalopathy, and variceal bleeding. So those are the features of decompensation. Bilirubin rise comes into that. So if the bilirubin starts going up, that is decompensated cirrhosis, terminal stages, right? That's one. Then at the same time, bilirubin goes up in acute liver disease. You know that cholestatic liver disease and acute hepatitis, and so. And also when you are checking bilirubin to be included in MELD score and so on, they have to be very careful, because there are so many conditions where there is indirect hyperbilirubinemia, like thalassemia, any other hemolysis condition, then Gilbert syndrome. So you get wrong values for MELD. So when you are calculating those, you have to be very careful. If the patient with well compensated patient has raised bilirubin, then it has to be, most of the time they are asymptomatic, it has to be Gilbert's. So make sure that you don't use those numbers to calculate MELD, because sometimes we get referred, patients gets referred with a very high MELD to see that they have thalassemia or Gilbert's. AST-ALT is reversed in cirrhosis. So usually if you don't have AST more than ALT, then you have a problem. So you have to find out why. In cirrhosis, usually AST is more than ALT. What's the other question? INR?
INR, sorry.
Yeah, INR, of course, is elevated in acute liver failure and chronic liver failure as well, and they are used to calculate MELD score for transplantation and so on. That synthetic dysfunction due to poor protein factor production. INR is elevated due to that synthetic dysfunction.
In patients with NAFLD with significant FIB4 score,
Yeah.
with high risk for fibrosis, should they be given obeticholic acid, and if so, the dose and for how long?
Yeah, obeticholic acid. So still obeticholic acid has not been recommended by any of the guidelines. That doesn't mean that we should not be using obeticholic acid, right? Because if they progress and develop decompensated, they are going to die. So people are using obeticholic acid because obeticholic acid is indicated for use of primary biliary cirrhosis. Because of that, obeticholic acid is in the market. 400 patient randomized control trial has shown that obeticholic acid is beneficial in advanced in fibrosis due to non-alcoholic steatohepatitis. Yes, you can use. There are two doses tested, 10 milligrams and 25 milligrams. 25 milligrams is better than 10 milligrams. Ideally, in patients who have non-alcoholic fatty liver disease and high FIB4 score more than 8, then in an ideal world, you should have a liver biopsy. And biopsy shows non-alcoholic steatohepatitis and fibrosis. They can be started on obeticholic acid, hopefully the higher dose. But very recently, India published the guidelines that allowing people to start liver-directed therapy like vitamin E, piometazone, and obeticholic acid without a biopsy on fibroscan evidence, FIB4 score evidence, right? So if you have high index of suspicions on FIB4, fibroscan, and the patient fits into non-alcoholic steatohepatitis, otherwise, we do start obeticholic acid without a biopsy. I have started, a lot of our colleagues have started, and India has officially allowed it to be started. So I think high FIB4 score more than 8. It has two side effects. One is pruritus and one is hypercholesterolemia. So if you can look after those adverse effects, obeticholic acid can be started. We have started. We haven't experienced any adverse effects, but unfortunately, we don't know whether they are going to reduce their fibrosis scores at 2 years because just we have started only during the last year or so, not before that.
So for how long should they be on the drug? What is the
obeticholic acid, the trial is for 4 years. They came out with interval results after 2 years. So they showed the 2 years with benefit, but FDA, the American Associate Drug Authority, did not accept and they did not approve it. So now they are continuing the 4-year trial. So after 4 years, they will come out with the results. So for us, I think it is at least it's something like statin. We have to maybe for life, don't know. So we have to wait and see the results after 4 years.
There are a few questions about using the anti-diabetic medication in CLCD, whether metformin causes lactic acidosis and whether it can be even in all CLCD, and what drugs are contraindicated in CLCD.
Right, okay. CLCD, compensated cirrhosis patients behave like normal people. So metformin is safe in compensated cirrhosis. So if you have diabetes and if you diagnose compensated cirrhosis, I hope you all know compensated cirrhosis. That's SI without ascites, without bleeding, without encephalopathy. So these patients, almost all our patients in the clinic, maybe 400, 500 patients are on metformin. We have not seen any lactic acidosis with metformin. That's theory, right? Statin, almost all our patients with diabetes and compensated cirrhosis are on statins. So all of them are on statin and we haven't seen a single adverse effect of statin. Europe is doing statin trial on decompensated cirrhosis. What else you can ask about statin? Okay.
Earlier, there was a concept of statin-induced fatty liver. Is this changed now?
No, there's nothing called. The statins are extremely safe on liver, as safe as any other drug. But same cannot be told about the muscle. Statin can cause a myositis from time to time. So if the patient complains of weakness or muscle pain, you have to test for CPK. And if the CPK is above 1000, you generally stop the study.
Can FIB4 replace FibroScan?
No, because first you do the FIB4, exclude patients with significant fibrosis. If the FIB4 is more than 1.3, you go for the FibroScan. You just can't start someone on obeticholic acid just on FIB4 score. The FIB4 changes. You do it FIB4 today, you will get 1.5. You ask the patient to lose 3 kilos of weight and 6 months, FIB4 score will be 1. Right? So liver stiffness measurement by FibroScan will not change like that. If it is say 9 today, even in 3 months time, it will be 9. So if you do the FIB4 and if it is more than 1.3, you do a FibroScan. If it comes as 10 or 11 or 12, then you have to decide whether you are going for a biopsy or whether you're going to start vitamin E or pyruvate or obeticholic acid. That's up to the physician looking after the patient with consultation with the hepatologist, gastroenterologist, endocrinologist. You can start whatever you want. But the best is, 10% weight reduction. Even for advanced fibrosis, the treatment of choice, the best robust evidence is weight reduction by 10%. It can't, obeticholic acid can't replace that true. So it's weight reduction. Additionally, you can start obeticholic acid.
Should alcohol be completely stopped in patients with fatty liver disease?
I think my answer is yes. So definitely for cirrhosis, yes, you can't take any alcohol in patients with cirrhosis because any amount of alcohol is going to increase the risk of hepatocellular carcinoma. For fatty liver also, now the answer is yes. You can't recommend it. I mean, how can we recommend alcohol even in small amounts in patients with fatty liver? It's something that causes fatty liver, alcohol.
Is obeticholic acid indicated in PBC only if ursodeoxycholic acid is not tolerated? In PBC, sir. It's regarding PBC.
I don't know, Felicia, to be honest with you. Who is asking it? One of our chats.
No, sir.
So that really I can't remember. It was tested because I think both for people who do not improve on ursodeoxycholic acid or people who did not tolerate ursodeoxycholic acid. Exact answer, I think they have to look for, but I am not very sure. Whether you combine it with ursodeoxy, I really can't remember. Yeah.
What is the duration of vitamin E treatment for NASH? Vitamin E for NASH. Duration, sir.
The duration, again, that study duration was 2 years, if I remember this study by Sanyal, right? But a lot of people feel is that it's not 2 years. A lot of people feel that it's long term, like diabetes, like statin, because unless you reduce the weight by 10%, it's going to come back. Those risk factors remain. So a lot of people think, but study has not gone beyond that period. After that, they have not been followed up, right? So a lot of people feel it's long term, but the study duration was 2 years, if I remember. So we have to, balance these factors and see.
One final question, sir. You said that NSAIDs are contraindicated in CLCD. What about COX inhibitors? What are your...
So we have had a discussion about that. So as a unit, we do not use even COX inhibitors in patients with advanced chronic liver disease. We have discussed that in detail in our unit. So we have not used even COX inhibitors in patients with any patient with compensated cirrhosis or decompensated cirrhosis in our unit. Theoretically, it may be used, but we are not recommending them because even COX-2 inhibitors can cause gastric irritation. As you all are aware, it can cause gastric irritation. So NSAIDs can give rise to upper GI bleeding. It can cause acute kidney injury. It can cause DILI, drug-induced liver disease. So any of these patients with any form of cirrhosis unlikely to survive a DILI, drug-induced liver disease. So we try to avoid all NSAIDs, including COX-2 inhibitors in patients with cirrhosis. But in theory, it may be used in theory, but we don't use it.
Thank you. So those are the only questions that we have had. So on behalf of the Sri Lanka Society of Gastroenterology, I would like to thank you for accepting our invitation and delivering this very interesting lecture, and for answering all those additional questions also. Thank you very much, sir. Thank you for your time.
Thank you, Kolesh. Thank you for participants. Okay.
Yeah. And for the participants, before you leave, it would be very helpful if you can answer the evaluation form. It's I have put up the link in the chat box. Thank you.